Good evening to you all. I'm sure everyone is now ready for our meeting. Today we are privileged to have our speaker. Our speaker is going to be Dr. ZiDA Sibanda, and she's going to give us a topic, and the topic that she's going to discuss with us today is tooth avulsion and endodontic consideration. I'm sure most of us know ZiDA Sibanda, Dr. ZiDA Sibanda. I'm sure for some of us who might not know her, she's one of our most senior colleagues, and she did the undergraduate degree at the University of Western Cape in South Africa. And she also holds a postgraduate diploma in aesthetic dentistry from the University of Pretoria, as well as a postgraduate diploma in endodontics, which she did as well at the University of Pretoria. Dr. ZiDA Sibanda works as a general dentist in Bulawayo, and she's very passionate about endodontics. She's passionate about saving teeth, no matter how hopeless they appear. So we welcome you, Dr. ZiDA Sibanda, to give us your talk on this topic. I'm sure most of us were going to learn a lot from you and enjoy.
Thank you very much. Can I share my screen now?
Yeah, definitely, you can.
All right. Okay, so good evening, colleagues. Like I said, I will be talking about tooth avulsion and endodontic considerations. So just to, I hope everybody can see the screen before I go on. Can you see my
we
screen?
can. Yeah, we can
Wonderful.
see your screen, Doc. Yeah.
All right. You may wonder why I chose this topic. I really decided to choose something that is something that we don't see on a daily basis. And yet when we do see it, you know, patients expect us to help them or to know what we are doing. It's something that I think because we're not familiar with, or we don't see these sort of incidences on a regular basis, sometimes, you know, you can be stuck and not really know what to do. So I just thought, let me revise one of these things, that a topic that maybe some of you last spoke about, or, you know, when you were at university. All right, so to begin with, we are going to define what tooth avulsion is. And it is the complete displacement of a tooth out of its socket. It has unpredictable outcome and long-term treatment burden. It can have a psychological effect, especially on young people, because as you can imagine, losing a tooth when you are young due to trauma, and if nothing is done, you know, to go through your young life, adolescent, pre-puberty without a tooth can really cause a lot of low self-esteem on a child. And what is the etiology? Basically, the etiology is, since this is something that happens mainly with children, sport activities, especially contact sports, it can be due to a fall, it can be violence of whatever form. And I'm sure lots of you will know that there are many other causes that can make it, or, you know, cause a tooth to come out of its socket. And just to mention also that teeth alignment also plays a big part in that, especially in cases of protrusive teeth, you know, like your class 2, skeletal class 2. So this is a typical picture. I mean, if you see a child like this and they're playing sport, you know that really one of the things you can recommend as a dentist is for them to use a gum guard. because the lip support is not so, the lip is quite thin around there, so there's not much protection. And, you know, in tooth avulsions, really the main culprits are the anterior teeth. I mean, rarely do we see molars or even premolars, back teeth coming out of the socket. Okay, so when we talk about tooth avulsion, we just need to bear in mind that the treatment protocol is going to involve 3 areas. It's going to involve the periodontal ligament, it will involve the pulp, it will also involve the tooth. So these are things that you just need to bear in mind. Okay, so let's go on to the treatment. Okay, before I go on, I must just say, sorry, maybe my slides, one of the things I struggled with is just to try and put the slides so that they follow each other nicely. But hopefully at the end, we will have a complete picture of the whole topic. All right, so in treatment, I've said that treatment starts at the site because you know, these are not like elective sort of procedures that we do. And in most cases, if we had to paint a scenario of a tooth avulsion, it will start off by a phone call from a parent or a guardian or a teacher or whoever, or even the child, I don't know. But, you know, they will call you in a panic. The tooth has come out of the mouth, you know, they've been hit by a hockey stick or whatever, maybe it's rugby. So what we need to do as practitioners is to be able to give important instructions there and then. So while you're on the phone, instead of saying, come here quickly, try and give the patient instructions or the guardian. And it's instructions on handling the tooth so that they know not to handle the tooth on the root, but they touch it on the crown. Make sure that they bring the tooth regardless of the state that it's in. You know, I had a case once where the patient actually drove halfway to my surgery and then later said to me, oh, do I need to bring the tooth? And I said, yes. So they went back, looked for it in the bush, and they found it. So they have to bring the tooth. Just remember that. And also, I always say, you know, the good thing is that these are, you know, you get a phone call before the patient comes in. So it gives you time to sort of take out your trauma guide and to prepare yourself. It's not something we do on a daily basis. It's not like your class 2, class 1 that you do, or your scaling and polish. So you may not remember exactly what to do. And, you know, there's no problem with that. And try and treat these cases as emergency, reschedule other patients, because really the prognosis depends on, you know, the promptness at which you treat these patients. So the treatment phases that I have, like we said, we start at the site of trauma by telling the patient how to handle the tooth. You know, it's something that, like I said, you can say to the patient, okay, handle the tooth like this, do this and that. But, you know, you can get a case where maybe the patient says, okay, doctor, I won't be able to get to you now. I am, I don't know, 3 hours away, 2 hours or whatever, or I'll come tomorrow. There's no dentist where I am. The thing is, you just need to gauge exactly what's happening at the scene. In a case where maybe the person has the tooth in their hand, maybe lucky enough it avulsed and it's in their hand, you know, by all means, let them re-implant it. They can put it back. Just tell them, push it back into the socket. It doesn't matter whether it's back to front, it's okay, because it's important that it actually stays in that, in the socket, if possible. And maybe they've got the tooth, they picked it up, it's not so dirty, they can run it in water, re-implant it. But also you may find that maybe they say, no, I'll be there in the next 15 minutes or so, what should I do? It's important for you to also just talk about the transport media in which to bring that tooth. So firstly, definitely they must not bring it dry. So they mustn't wrap it in a handkerchief or in tissue or whatever. Just ask them to put it in something wet. And you know, the suitable mediums for tooth avulsion are milk, which is readily available, cold milk. It can be saliva, where the patient can actually put the tooth in the vestibule, but also this depends on, you know, the age of the patient and in what state they're in. They may be panicking, crying, so you don't want the tooth in the mouth, or else they could swallow it. So maybe, if possible, they can be encouraged to spit in a little container, and then the tooth can be put in there. And if lucky enough that at a place where they can get hold of some physiological saline, maybe they can also put it in that, or they can put it in water. You know, I didn't put the one which is the Hanks solution, which is actually the most suitable, but I tried to make this to suit our situation in Zimbabwe. So that's why I didn't put that one. All right, so this patient now arrives at the dental office. Obviously, after you've calmed the patient down, taken them into your room, you need to make sure that when you take the tooth from them, put it in physiological saline. And then after that, you can proceed to do all other things like, you know, take the necessary treatment records, which will include your X-ray, the trauma history. You need to find out when it happened, how long ago, what happened, and yeah, things like that. And also, you may need to take your dental history. I forgot to put their medical history, would also be important. And then you will be thinking to yourself, okay, what am I going to do with this tooth? One of the things is definitely in terms of prognosis. There are many factors that affect prognosis, and one of them is obviously time. Prognosis is time dependent. The best time with the best prognosis is less than 30 minutes. And ideally, maybe you're looking at something like even less than 20, 15 minutes, it's good. And then if you get to about 30 to 60 minutes, this now becomes treatment dependent. So this is where the dentist really needs to have a very, very good understanding of what to do in order to shift the prognosis to a good prognosis, you know, because this is an area where you don't know, it could go either way. More than 60 minutes, the prognosis is guarded. So the treatment outcome, like we said, besides being time dependent, how long the tooth has been out of the mouth, it also is dependent on the transport media. Like we said, we don't want the patients to bring these teeth in a dry state. It must be in some media, some solution of some sort. And also there are good solutions. The best is milk, really, and then water is sort of the last one. But if they can find some cold milk, the chances are better. Maturity, the stage of maturity of the root will also determine your treatment outcomes. Either the root is a complete root formation, is in complete root formation, or it is an incomplete root formation, which has an open apex. Like we said, one of the things that are affected that you need to bear in mind is that the perioligament, the periodontal ligament conditions will be either viable or not viable, depending on how much time the tooth has been out of the mouth, whether it's been dry or not. So you'll find that in less than 30 minutes, if the avulsion happened less than 30 minutes, and you have to reimplant it, The periodontal ligament cells, some of them are viable. I mean, we can't completely rule out that there's some that have died already or not viable. And then periodontal ligament may be compromised if the tooth is kept in a media, extra oral time not more than 60 minutes. So this is really your time between the 30 and 60 where it is compromised, irregardless really of the media that you bring it in. And then your periodontal ligament will most likely not be viable if the extra oral dry time has been more than 60 minutes. Okay, so now going back to the dental office, you know, we can look at a tooth that completely with a complete root formation, or it can be a tooth that's with an open apex. So if the patient comes in and it's less than 60 minutes, you need to rinse the tooth carefully and keep it wet, obviously, in a physiological saline. You also need to handle the tooth with don't handle the root surface, and do not scrub the root surface either, and try and replant the tooth as gentle as possible. And what if the tooth has been outside of the mouth for more than 60 minutes? Extra oral dry time, 60 minutes. You know, a tooth that's been dry outside of the mouth for more than 60 minutes, here definitely you will have you know, your periodontal ligament and not viable, and then necrotic. So you will need to remove that tissue from the root surface. This can be done either mechanically or chemically. Usually what they recommend is that maybe you soak gauze in saline and try and clean it out. You can use ultrasonics as well. I don't know really, to be honest, how that would work, but yeah, maybe you wrap it in a wet gauze and put the ultrasonic to try and remove the necrotic tissue. Or you could use something like sodium hypochlorite, maybe a very low concentration like 0.5 or 0.1, somewhere there. And I've put a question mark there on the other one where you soak it in sodium fluoride, but it looks like there's quite a lot of literature that supports that. You soak it there for 20 minutes. It will really help to prevent or slow down the rate of root resorption, which we'll talk about later. And then later you rinse it for 2 minutes and you replant it and you split it. You splint, sorry. Okay, what about the socket? How do you treat the socket before you re-implant the tooth? So you'll need to aspirate without entering the socket. If there's a clot present, you remove using light irrigation with saline. And please do not raise a flap unless there is bony fragment, which prevents you to re-implant the tooth. But in most cases, this is quite rare. And if you find that the alveolar bone is collapsed, preventing reimplantation, then use a blunt instrument just to reposition the bone carefully before you reimplant. And then once you've reimplanted, you can use finger pressure to compress the lingual and buccal bony plates together. Suture any lacerations, especially cervically. Use a flexible splint for 14 days. And if you find after 14 days it's still very, very loose, mobile, then you can maybe extend the splinting for just 1 week, not more. And then obviously you give the patient home instructions no biting with the tooth, soft diet, stay away from contact sport, good oral hygiene with maybe some chlorhexidine mouthwash. So what type of splint, you would be wondering? Splint, very important that the splint has to be passive and flexible. You don't want a rigid splint so that your tooth is not mobile. And some of the splinting materials you can use, for those that know ribbon, it's just a meshy sort of ribbon that you can use. Or you can use fishing line, 0.13 millimeter to 0.25 millimeter. You can also use ortho wire, 0.4 millimeters. And I'm sure there is, a lot of you will know other splints that you can use, which are both passive and flexible. So just as an example, that is the flexible wire splint, where the composite buttons are put right in the middle of the tooth. Try to stay away from interproximal areas. Don't put anything also near the tissues, because you want the patient to practice good oral hygiene. So you don't want anything that will interfere with that. And that is the meshy ribbon I was talking about, which is called ribbon. You also use this to, it's quite flexible, and you actually attach it to the tooth with composites. Okay, now you've splinted the patient. So what is next? Medication before the patient goes. It's best to prescribe systemic antibiotics. I think the first choice would be amoxicillin, analgesics, mouthwash like chlorhexidine. Maybe it's wise, especially for teeth that you find in the bush, for the patient to have a tetanus boost within 24 hours. All right, so now, after this, one thing that I must just mention is the fact that, I'm sure everybody's aware that if a tooth is outside of the mouth, you've completely disrupted the neurovascular supply to that tooth. So there will be endodontic implications. And the endodontic treatment of these teeth can be divided in whether it's a tooth with a closed apex, complete root formation, or an open apex, incomplete root formation. And again, time is a factor, whether it's less than 1 hour of extra oral dry time or more than an hour will determine the type of endodontic you do there. So for a closed apex, which is a complete root formation or tooth with complete root formation, extra oral dry time of less than 60 minutes. Like we said before, best prognosis is within 20 minutes. So what you do is you need to make sure that within 7 days, between 7 and 10 days, not more than 10 days, you start the root canal. And you dress the root canal with an calcium hydroxide for 2 to 4 weeks. We're talking about a mature tooth here. And then later you can obturate the tooth at your second visit. After you remove the calcium hydroxide, you obturate with your GP and sealer of your choice ready. And then very important here is the follow-up. You follow these patients up for 5 years, and you've got to tell the parents right from the beginning, this is not like any other treatment. This has a long follow-up term. So the parents need to know from the start, otherwise they will think you're trying to make money from them if you call them every month. And really the recommended time is that you do it monthly, once every month for 3 months. Then you do once every 3 months for a year. And then later you can do your 6 monthly checkups, but up to 5 years, they need to be followed up. we'll see later why. Okay, so we spoke about the tooth with less than 60 minutes extra oral dry time. Now let's talk about the one that brings the tooth after an hour and it's been dry outside of the mouth for an hour. Here, definitely the periodontal ligament is likely necrotic. So you need to remove the necrotic periodontal ligament tissue completely. You using a saline salt gauze or chemically, like we said, using sodium hypochlorite, low concentration, but remove all of it because anything that you leave there will cause an inflammatory reaction and it will reduce your chances of success. And also you need to, in this case, because the tooth has been outside of the mouth for more than an hour, you can actually elect to either do the root canal intraorally or extraorally. If you can do it extraorally, or you can follow the protocol where between 7 and 10 days, you call the patient in to do the root canal. You know, personally for me, I think it's best to do it within 7 to 10 days because, you know, the choice of dressing in this case would be leather mix. And we all know that leather mix is tetracycline and corticosteroids. And that has a chance of actually leaking through the dentinal tubules from the pulp to the root surface. And it's been shown to have anti-resorptive properties. So maybe it's a good thing to dress it with leather mix. And then here you also do the, you know, follow up for 5 years and the same protocol that we spoke about, you know, once monthly, 3 monthly, and then once every 6 months for a total of 5 years. Okay, so we've looked at a tooth with a closed apex. Now, what about the teeth with incomplete root formation, open apex? A patient comes in and it's less than 60 minutes extra oral dry time. Very, very important. In these cases, do not do a root canal, but encourage revascularization. You know, with the closed apex, we cannot talk about revascularization because really the apex is closed. But in this case, in most cases, those roots have viable tissue in there which can actually regenerate. So you need to encourage revascularization and root development because the roots are still very fragile. The tooth could break. So the way you handle it is you soak it. It's actually advisable that you soak it in doxycycline for 5 minutes. They also say maybe you could also use minocycline before you re-implant it, also to just promote, to prevent resorption. And you follow up also just the same way we were doing the follow-ups, which is once monthly for 3 months, and then 3 months for a year, and then you've got every 6 months up to 5 years. Unfortunately, I'm sure there is chances that you may find that this pathosis develops, in which case you can remove the pulp and perform an epixification with maybe calcium hydroxide, MTA. I haven't really done too much research on this, but I think with revascularization, there is actually a chance of, with the epixification, I'm sure people that are doing peds will know about this. I think you can actually do it with calcium hydroxide or an MTA, or maybe use like the MTA as a blank, and then you put calcium hydroxide just to disinfect, and then later you fill with MTA. It would be interesting if the PIV guys can help us with that. But yeah, in this case, you do epixification rather than root canal. If it's been more than 60 minutes extra oral dry time, you know what, the chances of revascularization, to be honest, are low. But still, you need to give the tooth a chance. Do not do root canal. If there is one take-home message from this, is that for any tooth with an open apex avulsed, do not do a root canal. So give the tooth a chance and hope for revascularization. Because even if the revascularization will not occur, remember, we are talking about kids who are maybe 9 years, 8 years, 10. There is still the alveolar bone that still needs to grow as the teeth erupt. I mean, we all know that as teeth erupt, your alveolar bone will grow both in height and also in width. So you need to, you need to put the tooth there so that you can at least allow for that. And then you follow up, and if there's pathosis also, you perform epixification, and the follow-up is still the same, monthly, 3 monthly, and then 6 monthly for up to 5 years. Okay, so we've spoken about obturating, you know, doing root canal treatment, and obviously you may be thinking, okay, later we'll see that one of the problems that we have is root resorption. So here you need to use your judgment to decide what type of obturation material to use, even if you know it's a closed apex, because it depends if the root will resorb or not resorb. So in a case where there is going to be resorption, you really want to put a material that will resorb with the tooth. Otherwise, it means you need to, you know, if you put a GP, you may need to then take it out, do some surgery to take it out of the bone, and it's not necessary. And I must be honest, I think it's not an easy judgment to make, but yeah, good luck with it. So less than 30 minutes dry time, we know that the rate of resorption of the root will be low, so maybe GP is the best. And if it's more than 60 minutes of extra oral dry time, you replant that tooth with a closed apex, but you may get root resorption. So because it's high, here you may need to then think of a calcium hydroxide-based temporary obturation material. I mean, pure calcium hydroxide would be the ideal because really it's got no additives, but you could put something like Vitapex, although that can cause problems in terms of discoloration and if it's in the aesthetic zone. And there are many other calcium-based materials you could use, maybe UltraCal, I don't know what other ones they have, but yeah, something that's calcium hydroxide based. So this is a judgment that you make as a clinician. You know, do you think by re-implanting this tooth, the root is likely to resolve based on all the history you've taken about the trauma of that tooth and how it came to you? So with the follow-up, when you do follow-up and the patient comes, one of the things that I also learned the very hard way is that the first case that I had, I actually followed up that particular tooth that was avulsed and I put it back into the socket. And then a few years down the line, it could have been 5 years or so, or 4 years, I hope. I realized that, wow, the teeth next to that tooth which I reimplanted were actually undergoing resorption. So yeah, I panicked. Lucky enough, you know, there's an endodontist I know in SA that I discussed the case with. So all I want to say is when you do follow up of that tooth that has avulsed and you've reimplanted it, don't take the x-ray and look at that tooth. Look at the teeth next to it, either one tooth on either side or two teeth on either side, because you know this, the other teeth on either side of that would have been impacted by the trauma that the tooth in question, you know, underwent. So, and there may be things going on with the roots of those teeth that you're not aware of. So always make sure you actually follow up you know, an area. So you do your x-rays, you do your percussion tests, palpation, I forgot to write that. Okay, now they call them sensibility tests. That's your vitality test, testing for cold. I don't know if anybody does heat, but if you do heat, maybe with the GP, you can do that. And, you know, especially with children, with the PEDS and incomplete root formation, one of the things to look out for is infraocclusion. Because that is something that also you need to be, as a clinician, to know what to do to intervene at the right time so it doesn't cause aesthetic problems and future problems. Okay, I don't know if I should talk about this, but this is just a summary of management of avulsed teeth with an extraoral dry time of more than 60 minutes. So here they're already comparing a tooth with a closed apex and one with an open apex. And it's basically what we've gone through, where with the closed apex, you go ahead and you do your root canal. And open apex, you encourage revascularization. And then the rest is the same, you follow up and the splint that you put. Okay, so this is what is infraocclusion. So you may reimplant a tooth, maybe in a 9-year-old, 10-year-old, and later you see that there is actually a difference in the height of the teeth. You know, the gingival margin is not the same. Obviously, this shows that the tooth has been ankylosed. And if the tooth is ankylosed, there is no way it's going to erupt at the same rate as the other teeth. And it's something that can be corrected with by doing a decoronation. It's actually a very simple procedure to do. And I think ideally, I stand to be corrected, I think you have to do it before the age of 15. So hopefully somebody can correct me on that. Okay, so we've spoken about how you treat a tooth when the patient comes in, you know, covering things like your x-rays, how you treat the tooth, reimplanting, what you use to splint, and the instructions you give. But what is happening in the meantime with the roots of those teeth? Remember, we also say that with avulsion, it's not only your periodontal ligament that's affected, it's also your root. So this is really a description by Andreasen. I'm sure Andreasen is the father of traumatology, dental traumatology. I think all of us who've been through dental school have heard about Andreasen. So this is the type of resorption that he came up with, which is specific for tooth avulsion. So please do not confuse this with any other resorption. This is specifically to describe the resorption that takes place after tooth avulsion. So he classified them in 3 types. The damage is different, and so is the prognosis. So following reimplantation, your tooth can either undergo surface resorption. It can undergo inflammatory, which is also called infection resorption. It can also undergo replacement resorption, which is called ankylosis resorption. Just briefly, just the schematic drawing will show you that this is basically what happens in surface resorption. Surface resorption is one of those resorptions that we say is it's transient. So it's a resorption that will stop. It will start and it will stop as long as there is nothing else that, the patient is not immunocompromised, maybe. So following a tooth being out, or maybe I must just go through and say to you, on A, sorry, I should have had a pointer. A there, that brownish part is your dentine. The dark brown is the cementum, and then you can see your periodontal ligament, and next to that, you've got your bone. So with following tooth avulsion, obviously you've got rupture of the periodontal ligament, and then an inflammatory process will ensure, and it will occur on the root of the tooth. If there is no further trigger element, the body will repair, which is what... Okay. Okay, so like I said, if there is no further trigger element, the body will repair, which is what you see in slide C, where you've got new cementum, which has been reparative cementum that has been laid along the cement in slide C. And this type of resorption is actually a resorption which is uneventful, and there is no treatment that is needed here. And this is typical for a tooth that's been out of the mouth for the shortest time. So this is the ideal that you want to happen. And then you've got what we call inflammatory or infection resorption, which is of much more consequence. This one, it can actually carry on if you do not stop it in time. So what you see briefly there on slide A, you can see that the dentine has little black things. Those are your microorganisms, which actually, it's from the necrotic pulp. And in the dentinal tubules, you can see how the dentinal tubules are infected, and later the infection will go on along the root of the tooth. And unless you intervene in time, the inflammation, the infection can carry on, and you can actually get loss of tooth structure and even adjacent alveolar bone loss. But if you can remove the infection, then the prognosis will be good. So just to show you on an X-ray, with an X-ray, you can see that the incisor there was, you've got an incisor that had avulsed and it was reimplanted. And later there is signs, you can see the radiolucency around the apex of the incisor. That is actually infection resorption. So if you delay in doing a root canal, which is why they say do the root canal after reimplantation between 7 and 10 days, do not exceed 10 days, you can actually get inflammatory resorption taking place. But the good thing is as soon as you intervene and you do a root canal, you can actually arrest the process. It can stop, which is what you see in the third X-ray there. After the root canal is completed, you don't see the damage going further. So that is how your inflammatory or infection-related resorption occurs. And this is usually for teeth that have been out of the mouth longer than 30 minutes, or maybe between 30 and 60. Okay, so still on the topic of infection resorption, this is also what can happen. But I put this slide just to show you that, you know what, even if the patient comes to you 12 hours later, 2 days later, 3 days later, I think there's even studies on that. By all means, give the tooth a chance, re-implant it. So this was a 12-hour reimplantation, and obviously here you have infection related resorption at a 3-year follow-up. But you can see the tooth actually stayed in the mouth for 3 years. And maybe you, just to take note there, you can see that the choice of obturation here was GP. So maybe it wasn't the best, but anyway, there's infection around there. So you can remove, you know, once the tooth is removed or it exfoliates, it's not a problem. But I think, yeah, just the one thing I wanted to bring to your attention, give the tooth a chance. Okay, this is progression of infection-related resorption also in an untreated tooth. So if you reimplant a tooth and the patient disappears or you don't follow up, be assured that this is what is going to be taking place. You can see with your slide A there that immediately after reimplanting it, a few months down the line on B, you can see the arrow is pointing to resorption taking place on the roots there. C, it's a few months again. In a year's time, you can see the root is almost gone. So very important to do a follow-up. Okay, and then the last resorption type is what we call replacement resorption. This is really a competition. I always say this is more like a competition between the periodontal ligament and the bone. A replacement resorption, by the way, is also called ankylosis. You know, so here this also happens in young patients, especially, to be honest, when the root is not fully formed, open apex. So the tooth structure is resolved and replaced by bone. Like I said, it's called ankylosis. And it happens along the root, you know, several places along the root. And it can have implications, maybe, you know, if the orthodontist, I don't think they like teeth like this. Failure of the tooth to erupt along with other adjacent tooth. And this is what will cause your infraocclusion in young patients. And a very good sign that the tooth is ankylosed during your follow-up on an avulsed tooth. When you are doing your percussion test and you get a metallic sound, it's likely that there is ankylosis happening. No treatment, but it can be, it cannot be, you can't do anything really about this. Okay, so this is just another slide where I wanted to show you just some of the bad scenarios, you know. Like I said, give teeth a chance, Doesn't matter how many hours they present to you, doesn't matter how dirty it is, clean it. If it means you remove all the necrotic tissue and periodontal fibers, that's fine. Just put it in there. So in this one, this is an 8-year-old, 2 hours after trauma. The tooth was cleaned. You can see what happened there, reimplanted, splintered. And 2.5 years, almost 3 years later, the tooth was still in the mouth. At this time, the child is almost 11. So at least the child went through life with the tooth. And this is typical of replacement ankylosis, replacement resorption. You can see that the root is being replaced by bone. There is no infection actually in root in ankylosis, in ankylosed teeth. And I think here the choice of obturation material was a good one because it was calcium hydroxide and it resorbed along with the tooth. Okay, that's another picture of infraocclusion. It's not very clear here. And just one thing to say about this infraocclusion is the younger the patient is, the more obvious it is. So if the patient is a little bit older, you know, it's not as noticeable. Maybe this one, they could get away with it. But if a child comes to you like this, really, you know, you need to perform a decoronation here. The tooth, the ankylosed tooth has to be removed. So you raise a flap there and you remove the crown. And then later, just 2 millimeters below the alveolar bone of that tooth that you've removed, you then cut the root and you suture everything back. Like I said, it's quite a straightforward procedure, but it just helps to maintain the aesthetics. It helps because later the patient will need, whether they'll have an implant or they'll have a bridge, but at least you have preserved the aesthetic. Otherwise, it's much more difficult to correct later. So when placing, so you can see there's the X-ray with the piece of root that is in there. The crown has been removed. You've done a decoronation there. And you place a temporary crown. You place it in such a way that you leave 2 millimeters of space so that the bone can remodel. And because the bone will remodel and come to the height of the other bone. So there is another schematic drawing of decoronation there that you can do if you have that happening. So like I said, it really, avulsions carry a long-term treatment burden, you know, so you need to really just sit down with the parents and tell them about all the possibilities that can happen so they are not surprised. So you can see this is a beautiful result. After the decoronation, you can see that the alveolar bone level has grown to catch up with the other one. So yeah, so okay, I hope I made sense. I hope everything is making sense now that I'm done with my presentation. And in conclusion, really, one of the things I want to mention is that I look at it as a teamwork. It's not something that you can do on your own. Sometimes it's good to consult other, people that maybe are more experienced than you, have been in the profession longer, have seen these sort of cases. So don't feel alone if you get any trauma, trauma cases and you're not really sure what to do. I think, we're really here to help each other. And these traumas happen in children. And the worst thing that you can do for a child is to actually throw away their teeth or not do something to at least, put back that tooth in the mouth. and let them go through the adolescent, the childhood, without so much psychological impact and low self-esteem. I always say, you know, my one friend who I worked with, Dr. Miller, always used to think that I used to perform endodontics. I'm one person that doesn't like removing teeth that much. You know, I do all sorts of crazy things, but I think as I get older, I'm learning what works and what doesn't. So anyway, the goal is to limit root canal infection and periradicular inflammation, shifting the balance from unfavorable to favorable healing. Success is dependent on the duration and extraoral conditions of tooth preservation, degree of damage to the periodontal ligament, and condition of the pulp. The age of the patient and the manner and duration of splinting is important to the healing process. Remember, please always try and save the tooth. There's a lot now about regenerative dentistry and stem cells, and I'm sure a lot of people that have done some studies, specialties, that they know about that. And I would like to recommend this website. It's for free, a dental trauma guide. You can get information about treating any trauma in dentistry, whether it's luxation, avulsion, or I don't know what else is there. But yeah, and let's see. I think that's it. I hope I made sense. So thank you guys for listening. It's been too quiet, so it would be nice to hear somebody's voice. By the way, the comments and discussions and questions are for all of us. So if I don't know anything, please guys, feel free. Those of you who may have experienced, you're welcome to comment. Thank you.
Thank you very much, Dr. Sibanda. I think our moderator just dropped off. We have Dr. Vicky.
Good evening. Thanks, Dr. Juju, for that great lecture. Are there any people with any questions for her? Do you have any questions for the speaker? Let me just check the chat box. So in the chat box, so far, we are very informative. Dr. Dudu?
Yes, Dr. Vicky.
Are you doing any regenerative endodontics yourself?
I think the truth is I haven't come across a case that has needed that, thankfully.
Okay.
Yes.
All right, no, that's fine.
I should be asking you about that maybe.
Yeah, it's not as easy. Yeah, it's not that easy to do, but.
Okay.
Okay, we've got Dr. Tendi who says he wants to add something, I think.
Yes, please.
I think so. That's what it says. Then we've got Dr. Chironga. Yeah,
Yes,
you
Doc,
can go ahead.
Okay, so with the open apex cases, I just want to add that I would advise the practitioners to avoid instrumenting the tooth. So since it's an avulsion, you try to make sure that before you implant, you reimplant the tooth, you measure the length so that after the 7 to 10 days of splinting, you already have the working length. And then if you choose to do a regenerative case, you are looking at an apex that's at least size 55. The apex should be at least size 55. So that's 55, 60 going up to 80, 90. So if you choose to do a revascularization, actually, it's not regeneration, revascularization, you don't instrument this way. You need your irrigation and your rubber dam just to make sure you get enough concentration of hypochlorite. And then you dress it up with calcium hydroxide for another 2 weeks. And then after the 2 weeks, your final rinse should be your hypochlorite. You dry the canal. After drying and when you're placing your calcium hydroxide, you're just aiming to make sure the calcium hydroxide is along the walls of the root canal, not flood the whole canal, because you may extrude some of it into the apex. And the excess calcium hydroxide tends to cause some partial necrosis. So if you, on the obturation appointment or the revascularization appointment, your final rinse should be hypochlorite. You dry the canal, you take your sterile file, you intentionally cause bleeding into the canal. And then you get your cotton pellet that's in normal saline, you try to get a blood clot in the canal itself. Then you place your MTA, and then on top of the MTA, you place your flowable, and then you build up. But if you choose to do an apexification, an apexification, I would suggest you use MTA, but then in this instance, you have to be taking a lot of x-rays. So you pack your MTA. It doesn't matter if you extrude because MTA is biocompatible. So you keep packing, you pack, you take another x-ray, you pack again, just to aim to get at least 5 millimeters of the MTA at the apex. So you already have your working length, and it says 21 millimeters. And then you pack your MTA at least 5. So you're aiming to get your file to get to, so 21 minus 5, maybe 16 millimeters. Then you know that you have at least 5 millimeters on the apex. And then after that, you backfill with your GP on top of the MTA. You backfill with your GP on top of that, then you composite, then you build up the two. So that's what I would suggest. So in an open apex case, try to avoid to instrument so that you don't weaken the root dentin. You work with your high concentration hypochlorite, rubber dam, ultrasonics, or agitate with your GP point as much as possible so that you may even catch those lateral canals, and then that's it. That's all I wanted to add.
Thanks, Doc.
Actually, thank you, Dr. Tendi, for that. Yes, I was going to say thank you. And I think this is one of the things I was trying to emphasize, that don't feel that you are alone. I don't know how many of you still remember every word that Dr. Tendi said, but for me, I think now I know if I have a case, I'm going to call him and he can help me. So it really has to be multidisciplinary. You know, I think in Zim now we've got enough professionals that can help us with the different cases we come across. So thanks for that, especially the one about measuring the length before. I didn't think about that. And yes, I'm also an advocate for rubber dam. It really will increase your success rate for getting into the pulp, whether you're doing a pulp cap or doing a root canal. So thank you.
All right, are there any more questions or comments before we close the meeting for today? All right, it seems there are no more comments in the chat box. So again, thank you, Dr. Dudu, for that great lecture. I'm sure everyone learned something they can use in their practices. So call it an evening. Good evening to everyone. Thank you.
Thank you.
Bye.
Bye.